Good afternoon and welcome to Webinar Wednesday. Today we are joined by Ty Greenhalgh, Industry Principal Healthcare Medigate by Claroty, and Skip Sorrels, Director of Cybersecurity for Ascension Health. Webinar Wednesday, we'd like to thank our sponsor, Medigate by Claroty. As the world's most trusted healthcare cybersecurity company, Medigate by Claroty empowers HDOs to comprehensively monitor and manage risk across their healthcare extended Internet of Things environment. Whether it be through a medical device or a building management system, attack surfaces grow as connected assets expand, creating security blind spots that pose risks to availability, integrity, and safety. Claroty tackles these risks to ensure cyber and operation resilience are within your reach. So for more information, please visit claroty.com. Just a quick reminder about saving the date for our fall MD Expo. We're headed to the Mohegan Sun Casino and Resort in Connecticut from October the 8th to the 10th. Join us for 3 days of education, networking, and the latest advances in medical technology products and services. For more details about this, please visit mdexposhow.com. And also just a quick reminder about our HTM Mixer, which is being held at the Westin, Indianapolis next week, May the 2nd and 3rd. Our mixers are a slightly modified, smaller, shorter duration and less crowded event that still provides valuable continuing education, networking and vendor engagement opportunities. So for more information and registration details, please visit htmmixer.com. I'd also like you to remind you that TechNation magazine is taking applications for our 3rd annual 40 Under 40 powered by YP at AMD. We're looking for HTM professionals who are under the age of 40 who have done amazing work for the biomedical industry. Applications are due by this Friday, the 26th, so please visit TechNation or see the flyer in the handout section of your dashboard to apply. Today's webinar is eligible for 1 CE credit from the ACI and to obtain your CE certificate by completing the post-webinar survey. The survey will be emailed 1 hour after the completion of today's webinar, and you must complete the survey to receive your 1 CE credit. You'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Okay, let's kick off today's webinar by giving away one of our Webinar Wednesday 10th anniversary prizes. Today's prize is a $100 Amazon gift card. So using the questions feature on your dashboard, let me know the answer to the following trivia question. April is National Pecan Month. Which state is the largest producer of pecans? I'll reveal the answer and our winner at the end of the webinar. We'll be wrapping up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on the dashboard. As I mentioned earlier, our presenters today are Ty Greenhalgh and Skip Sorrels, and they will be discussing securing patient care insights from the state of CPS Security Report. So Ty and Skip, you may begin whenever you're ready.
Well, thank you very much. And it is absolutely an honor to be here at TechNation. I remember, for years, I've listened to this, also the magazine and so many articles in there from people like Phil Englert or the team over at VHA that put so much information out there and networking information. There's just, it's an honor to be a part of this and to actually be presenting, and especially here with Skip. I mean, what a tremendous resource he is of knowledge for the industry. So the listeners today, I think you're going to be delighted with what we're going to talk about. We're going to be talking about. So we put together Medigate by Claroty put together a report we're going to talk about. And so I know a lot of people, oh, report, what's that? We're going to make it relevant for you here with respect to HTM. And I know that, I always say that 87.53692.4% of all statistics are made up, but we're going to make them relevant for you here today. And it's again, just an honor to be here. My name, Ty Greenhalgh. I am the industry principal for healthcare here at Medigate by Claroty, and I'm with a number of work groups with respect to the kind of it's the political landscape, but working with the government agencies and trying to help create best practices for cybersecurity in healthcare. I've been doing that since, I guess, around 2017, 2018. And we're going to kind of weave that into this as well as in why it's important to you. What would love, Skip, if you wouldn't mind introducing yourself and telling us a little bit about you and your role and a little bit about Ascension.
Thanks, Ty. Appreciate it. Happy to be here. It's an honor as well. I was looking on the calendar, Ty. I think it was almost a year ago to the day that we did a TechNation presentation, if I recall. So it's good to be back. Skip Sorrels. I'm one of several directors at Ascension in cybersecurity. I have a focus and a practice around med device security and operational technologies specific to our healthcare organization. I've been in this role about 6 years. Started 6 years ago to build this program. It didn't exist at the time. I've got about 26 years in technology, and prior to that, I was actually a nurse. Went to school to get my bachelor's and did ICU and trauma nursing. So come full circle in that I'm back in healthcare. I love it, and I like to leverage my understanding of it with regard to cyber. So it's a good match for me. So thanks for having me.
So tell us a little bit about as you look at your organization from a medical device perspective. Can you tell me a little bit about that and how you're engaged?
Sure. So the landscape of Ascension is quite large. Depending on what metric you look at, we're one of the largest nonprofit healthcare providers in the United States. We've got about 140 hospitals, 2,600 locations, and over 120,000 medical devices across that footprint. So it's quite vast, expansive, lots of diversity, and lots of things to look at, and also many things to apply practice to and secure. So it's an evolving landscape, and it's almost daily. Cyber alone is daily, but even in the healthcare space, with the things that we're beginning to look at that other entities or industries looked at years ago, we're finally trying to catch up, so to speak. And it makes for a very challenging but also very exciting opportunity.
Awesome. So the agenda today, we're going to talk a little bit about our Team 82 report, the healthcare cybercrime, quick overview, kind of what's going on. What are the top healthcare threats, and the cybersecurity strategy for HHS, and then how does this all really relate to the findings in our report of basically what we call cyber physical systems, or basically in this particular case, it's medical devices, and the statistics with respect to cybersecurity on medical devices. So the report from a high level it's generated by what we call our Team 82. That's basically the cybersecurity arm of Claroty. They how do you even describe this team of people? These are our hackers, and I was just reading one of their reports. They find a lot of vulnerabilities out there. They watch a lot of attack patterns and figuring out indicators of compromise. But they recently wrote a report on a thing called Fuxnet, and it's kind of like Stuxnet, I guess, with if you all are familiar with what happened in Iran and the centrifuges, and it kept blowing up because of a programmable logic controller that kept spinning the centrifuges too fast. They just did a report on what's going on from a Ukrainian perspective, attacking the Russian infrastructure, and exactly how they've gone about attacking and turning off gateways and bricking them so that the sensors don't work, and so all the controls across a number of different critical infrastructures are degraded. And it's so this is, I mean, that's the type of that's that's the team that's helping us put together our software and our solution. It's absolutely the best out there in the country. I mean, they go to competitions and win stuff. It's crazy. They're crazy smart. And so they're the ones that put this report together based on a lot of different data, our data across 2,000 hospitals, as well as the National Vulnerability Database information, CISA data, as well as the Healthcare Sector Coordinating Council Cyber Working Group, which I'm also a part of. They're under HHS. So a lot of data that we've brought together so when you look at these statistics, you'll know there's a lot of work that's gone into them. But just from a healthcare perspective overall, the bad guys are getting faster. They're impacting patient care. When a hospital gets shut down, they shut down, the medical devices as well, and diversion from ambulances, cancer patient treatments, just appointments get backed up. Care is impacted, and therefore outcomes are degraded. And from just a breach and records perspective, last year up only slightly in the number of breaches, over 500 records. It's over 500 records that need to be reported to OCR. And but the number of records covering the 590 almost doubled. So these records are very expensive. They're very valuable. They're the most valuable out there in any industry because of all the data types that are there that can be taken and sold off. They're impacting about $8 trillion annually from a cybercrime perspective, which is the third largest GDP in the world, only behind the United States and China. So when you think about this, it's something a hospital can't stand up against that. So the government has had to get involved. And so with that, we're going to kind of weave in what the government is doing, how that applies to HTM and clinical engineering now, because there's been some changes that have just happened that are going to bring this to your doorstep and create new opportunities for you. So with that, we created what's called a landscape analysis at HHS. And here are the 3 top threats. It's basically the attack vectors, really, is how the bad guys are getting in. And Skip, can you talk to these 3 at a high level and just tell me what your thoughts are on these and maybe how it applies to what you're doing at Ascension?
Sure. So I think the thing that people are probably most familiar with is the social engineering aspect when they hear the terms phishing, vishing, smishing. And basically that's leveraging technology to punk somebody, for lack of better words, to take advantage of their system, either a text or an email, and to solicit an action, right? Sense of urgency. Warning, you have this virus potential in your computer. Please dial this number so that we can help eradicate it. That's a form of social engineering. Third-party compromise is going to be things that occur in the supply chain. Hackers have gotten into companies and created backdoors into their software that was then propagated through their customers through their distribution model. Third parties can also be Change Healthcare, been in the news a lot lately. The biggest company that provides transaction in the financial aspect or the money revenue cycles for all the hospitals in the United States, and probably even larger than that from my lack of understanding. But it's a big deal, right? Taking them out impacted healthcare and healthcare organizations' ability to function financially. When you look at the third one, system vulnerability compromise, that's when we start talking about systems that aren't patched. There's an update that comes out for a computer, a server, a med device, and a patch doesn't get applied, which leaves an opening that the hackers have figured out, and they take advantage of it. And they're able to overtake that machine and begin to do various things with regard to privilege, access, traversal, acts of hacking that allow them to further penetrate an organization through a single device. So the last being privilege escalation. It's really not the last, it's the end game of each of these methods of attacks. The hope being that they can gain access, and then more importantly, get access as an administrator on systems so that they can make changes and do things that are not good for that environment, take advantage of it.
Nicely said. So as the landscape analysis itself was a composite of a number of different studies, and you can see the common points of intrusion there at the top. But then when you start taking a look at this, really a lot of people are already doing multi-factor authentication and on email, but it's not 100%. And so that's one point. So as you start looking at some of the data within the landscape analysis, it's saying that, well, while a lot of people are doing well, we need to be doing better. And then only 49% have adequate coverage on third-party risk. And investment in cyber, it's across the board, depending upon how large the organization is. You got small hospitals that are, basically financially poor, but they're great targets for hackers. And whereas large hospitals have a much bigger budget. Skip, do you have any thoughts with respect to investment in cyber and where you see that going, or maybe how your organization looks at it?
I don't think we're any different than what the landscape analysis finds. We're focused on those three imminent attack vectors because they're the most prolific. We are not rich in terms of financial resources or people, comparatively speaking to other industries. So we have to be very lean and mean, so to speak, in the sense that we don't have the ability to buy all the latest and greatest tools. We have to be very selective, and we have to be very focused on the fundamentals. The fundamentals always play into your technology, and that's your governance, it's your asset management, it's knowing your environment and establishing the appropriate security layers and measures that create the barriers to entry and to compromise. So we take all of this very seriously and holistically. But I'll always say, Ty, at the end of the day, it boils down to basic blocking and tackling, and you got to start there.
Yeah, so true. All the best sports players, the ones that have been just the standouts across any sport, you ask them, there was always basics. But I'm glad that you also brought out asset inventory. We're going to talk a little bit more about why that's so important a little bit later, as the data has kind of ferreted out, as well as some of the new legislation. So speaking of the new legislation, for those of you who haven't heard this, really you need to kind of put on your active listening, stop multitasking, and there's three different types of people out there: those that can count and those that can't. So if you didn't get that joke, you're still multitasking, and you probably need to listen to this. That HHS has a new cybersecurity strategy, and it's back in December, they said that there's 4 things they're going to do. They're going to create voluntary cybersecurity performance goals, which are not going to be voluntary very long. They are going to create incentives, monetary incentives for hospitals to put in these practices. And then they are asking for more money to increase enforcement, kind of like the 87,000 IRS agents, I guess. They're increasing their enforcement capabilities to make sure that you are doing those. If not, there's going to be penalties, financial penalties. And to make it easier to kind of work, they're going to change HHS around a little bit and make it easier to work with. So that was just back in December. And so they've already come up with their enforcement and incentives that they're proposing. So taking a look at the White House budget and the HH budget brief, all of the documents that we're talking about in here are in the resources, hyperlinks in the end of this document, so download it out of the show notes, or reach out to me. I'd be happy to get you this stuff. But basically, they're going to create two categories: one, essential, and in fiscal year 27, 28, that's basically September, October 26, starting on this, $800 million for small hospitals. And then if you are not doing these things by FY 29 and 30, you're going to get up to 100% of your market basket update reduction. So there's a definition of market basket update. Basically, it comes down to around 2 to 4% of your Medicaid, Medicare reimbursement, which is a huge number. Ultimately, what I'm saying is senior leadership is going to, this is back with like meaningful use, where we had to put in an EMR, and it was just, it took everybody's attention, and senior leadership, you know, is all about that, right? This is, we're going to be all about this again, because they can't afford, hospitals can't afford to lose 2 to 3%, 4% of their reimbursement from Medicaid, Medicare. And even if you're a critical access hospital, CAH, that's 1%. That's too big a number. So they're going to be looking to different departments, individuals, to take responsibility for these goals. And this is where I'm saying this is coming to the HTM department. So in fiscal year 30, you know, they're going to even have more penalties. And then the enhanced list of goals, they push that out a little bit more for, you know, larger hospitals, all hospitals, but same type of idea. So before I just move through this, there was a lot of information. Just give you the opportunity. Skip, anything you want to add to this slide?
I think the only thing that, I don't know really if it's an ad, it's an observation. It's really, I look at it from the perspective of, you know, where do we sit right now? What's our baseline, and where do we need to be? And more importantly, most importantly, ensuring that my leadership from all aspects of the organization understand this is coming, and we all need to be prepared for it, not just the security folks and the HTMs. It's going to be a team effort to accomplish these things.
Great point. Great point. It all starts with getting the team together. I can't tell you how many different types of technology I've put in over the years that have been, you know, kind of new and made departments work together that never worked together before. This is absolutely the case here. You are absolutely correct. So as we move forward, so what are those two? What is the list of essential goals? What is the enhanced goal list? Well, here they are. 10 each, 800 million for the essentials, 500 million for the enhanced. And so if you kind of break this down in the essentials, there's about 2,000 small hospitals, $800 million, that goes to about 400,000 per. I've heard some people call it budget dust because it's not enough, but it's a good start. It's absolutely a good start. And these are kind of the basics for smaller hospitals to get started, and then the enhanced goals, they're feeling like those are absolutely also going to be required, but maybe a little more advanced, takes maybe a little more effort to embrace those goals. And so with that said, what we want to do is we want to say, okay, so this, why it matters to you, and bring the report that we did here at Medigate by Claroty together and take a look at this stuff. So as we take a look at those essential goals and the landscape analysis that said the top the top vector, social engineering, those essential goals actually are apply to solving the number one problem we have, which is social engineering. Would you agree with that, Skip? Do you think that, you know, those are a good set of controls or goals to be working on for that solution?
Yeah, absolutely. I mean, each one of those data points under the goal, or I should say, each one of those goals is a vector for a form of social engineering or the protection against social engineering. So definitely.
Can you talk a little bit about, maybe some of the ones that are like why unique credentials, or why separating users and privileged accounts?
Sure. So I'll start with unique credentials. In any organization, there are often software applications that have hard-coded passwords. There's often what are referred to as generic accounts, which might be admin password. I hate to say it. There's default passwords, and those are used by many different people, and sometimes even used as service accounts to run the application. The problem with that is you don't have specificity. And what do I mean? When you're looking at your logs and you're trying to determine if something's going wrong and you have a generic user ID, it makes it really difficult to dig into the data and make a determination if the actions are warranted or unwarranted. So logging, specificity of user, and function of user account play into understanding good and bad behavior. You then get into the separation of privilege. So, most people in corporations log into their laptop, they have a username and password. That would be what I refer to as a daily driver. It's how you access your system. And then there's privilege. And privilege constitutes something more than general use. Maybe being an administrator on a server, having admin rights to switches and routers, equipment in the infrastructure, and even administrative privileges on medical devices or operational technologies. If your daily driver is also your admin account and your system, your local system, your personal account is compromised, that's direct entry into an administrative environment with the ability to do bad things. So we want to air gap the two. What I mean by that, you have a daily driver, but then you have to access a system or have a means to access your privileged credentials, keeping those completely separate, air gapped, so that you're using the administrative in an administrative role and function, and only during those actions, and your daily driver while you're performing your daily work. And that prevents a barrier to entry for hackers, somewhat.
Beautiful. Yeah, somewhat. Always the caveat, right? And as we move to the third vector there, which is really system vulnerability compromise, really thinking about, is it facing the internet and the type of vulnerability? Okay, so because as you expand out, again, the links will take you to the web page here where all this is available for you, and you can expand out any one of these and know a little bit more about it. This was the very first one under essential goals, which is mitigate known vulnerabilities. Well, that sounds pretty straightforward. And the description is reduce the likelihood of threat actors exploiting known vulnerabilities to breach organizational networks that are directly accessible from the internet. So, okay, so there's a device with a known vulnerability that's directly accessible to the internet. Yeah, that sounds like that's a front door on the house left open. We should probably close those and lock them. That's probably a pretty good place to start. Would you agree, Skip?
Absolutely. One of my teams in the past was our pen testers, so our ethical hackers. And many years ago, I was having a conversation with them, and I was fascinated by the world of hacking and the shows and the exaggerations that you see about these hackers and just banging away at a keyboard and doing all this. And it kind of hit me one day, and I just kind of looked at my team and I said, it's really not that difficult, is it? Because it's kind of like walking through the neighborhood, walking up to a front door, rattling the doorknob to see if they locked it, and if not, you walk in, and they're like, absolutely. Path of the least resistance is always the choice for a hacker. It's not often the complex things they go after. You start with the little things and you expand your attack from there.
Yeah, and I would say that part of why we're showing you this is Medigate has constructed their solution in such a way that we actually address the majority of these goals. So all in different ways, but then integrate the information and data together in a way that allows workflow of, how do you detect the vulnerabilities? How do you identify the devices that have known vulnerabilities? And then what are you going to do with them? And how are you going to tell the correct individual that's responsible for that particular device what it is they need to do? Because when you're talking about, like in Skip's case, 124,000 devices, well, it's got to be efficient, effective, and it's got to scale. So, all this has to work together as well. But this one right here is just a standard report in our solution. Whereas if you think, how am I going to do this with medical devices? I don't even know all the devices that are on the network, let alone what the vulnerabilities are. So again, I think there's going to be it's going to be wise to consider solutions like Medigate in the solution set for addressing and being compliant with these new regulations. So as we look at the data we found across all of our analysis by Team 82, as far as all the devices that are device capable of internet communications there in the top left-hand corner, 72% of the devices are attached to the internet. And 14% of those medical devices run on outdated operating systems. How vulnerable is a device, Skip, that is running an outdated operating system? What does that mean?
So if a medical device is running an outdated operating system, that means the manufacturer of that operating system no longer looks for vulnerabilities or patches vulnerabilities from the point of end of life, end of service. So if you couple that with vulnerabilities that may have been there in the past, could have been patched and weren't, coupled with additional vulnerabilities that can be identified, you kind of have a situation that's ripe for the picking, in that all of those vulnerabilities of the past are cataloged out there publicly, no different for us or them. So, the hackers they're not ignorant. They go looking where they can find open source information and determine what things they want in their toolkit to go take advantage of particular vulnerabilities. And then it's a trial and error process.
Yeah, and I mean it's the money that they're making. Again, it's I think over $1 billion last year in total ransomware. This is big business for them. These are smart, organized people that are in the middle of nowhere with no job opportunities, but they can do this from anywhere. It's not going away. We have to make it harder for them. And so knowing that medical devices are an open, may not be an open door, but they're an open window. And then down, as we move down, we look at the types of devices that are attached, and we've got the volumes there. It's imaging workstations, huge from a vulnerability perspective, and 32% of imaging devices are running on outdated operating systems. And then part of the problem that organizations have is they use their IT cybersecurity solutions because they don't have a Medigate. And so they go out and they look at their network, and what their solution tells them is that's a PC workstation, and it's got, say, Windows on it, and it's that's got the outdated operating system. But it's not. It's really an imaging workstation or it's some other type of device. It's a gateway for infusion pumps, or it's something, but if you can't identify what the device is, you really can't start solving the problem. Would you say that you used to have that problem, Skip, and now you don't?
No, it's an ongoing problem. The fundamentals from my perspective of why do we have outdated anything is a reflection of lifecycle management. Medical devices historically were built to be long in the tooth, meaning big iron lasts 10 to 15 years. It's often referred to as useful life. Yet the end of life and end of support aspects of that device are tied to the software and the operating systems that often expire before the useful life of a device expires. So you're left with a gap out in the ability to secure it. You couple that with a lack of a view and understanding of what's out there, because again, medical devices were never really contemplated as part of the IT infrastructure. It was a clinical application or device. And so lack of funding, awareness, and understanding of refresh cycles and the need to keep them current is just now coming to the attention. I would say, again, in the last 6 years, as I built out this program, there has been an increased interest in this and a realization that the lack of funding and visibility and lifecycle management are the the root cause of that problem.
And could you talk a little bit about there's one of the things I think that hospitals run into, especially HTM, is they go put in a tool like ours, and all of a sudden we identify all of these vulnerabilities. Because I think some people have said there's 1,400 vulnerabilities per medical device or something crazy like that. But they're not all equal, are they, Skip?
No, they're not. And as your slide begins to paint that picture, I'll speak to it a little bit. So the outer circle represents, let's just say, all of the vulnerabilities that can be identified. And as those circles decrease, we get to the inner circle, the center circle, where we're talking now about exploit predictive scoring. And that's the ease and ability of a vulnerability to be taken advantage of within a forecasted 30 days of its identification. You then couple that with what's known out in the wild, we refer to it as threat intelligence. What are they actually going after? And those are known exploitable vulnerabilities. And so when you think about how do you tackle this huge mountain Everest with all these vulnerabilities in its overwhelming quantity and effective manner, and you have to shift your focus to those known exploitable vulnerabilities tied to systems that are patient safety risk. So the prioritization gets centered on patient safety and patient outcomes with a focus on those first as you go down in the stack rank of criticality as it relates to that patient safety. Again, coupled with the knowledge that they're actively exploiting said vulnerabilities on systems. That gets you to a Pareto principle from the data that I've looked at, that others have presented and looked at, and I think would play out here. And it's almost the 80-20 rule. And when you get down to that smallest circle, estimates indicate it's anywhere from 5 to 8% of the total number of vulnerabilities in an organization. Total, not just med device, total. So it becomes a workable, manageable focus area.
And would you say that HTM is a critical component in there to decide from a criticality perspective of, what devices are going to impact business operations more, or which ones are critical? And again, going back to your comment about, it really takes a team now.
Right. HTM's actually the tip of the spear, in my opinion, because they are the most intimate and the ones that also document in the most detail the requirements necessary to meet the JCO audits that happen. And that is the designation of patient safety and criticality of each of the assets. So they're a direct link to a better understanding of what presents the biggest risk, and tie that to, through security, the KEVs in the environment for those devices. Absolutely a team effort, and HTM is at the forefront of that with their experience and knowledge, not to mention an understanding of what's going on in the clinical space and whether devices are in use or not on patients, which plays into how do you schedule these updates and do it in an offline mode, off patient mode.
Yeah, and I'm a CEO or board member at a hospital, and I start looking at these new regulations, and the enforcement mechanism is going to be CMS telling the Joint Commission to come in and do cybersecurity audits on these new HPH CPGs. And I'm looking at, okay, so is this going to be IT that's going to be responsible for the Joint Commission? Is it going to be security, or, clinical engineering, who already works with the Joint Commission audits? And this is probably going to be under environment of care. So again, I'm just trying to let you know that this train has left the station, and it's going to be, HTM is a stop on its way, and if you kind of, the reverse of KEVs is what we're seeing here. Is look at all the unsupported operating systems with high EPSS scores. If I said, okay, I'm going to use EPSS to assess where I need to spend my resources, I don't have enough resources to do this at most hospitals. That's part of the problem. So you've got to be more strategic about how you're going to be applying your limited resources, and therefore this known exploitable vulnerability is what you want to go after. So the whole beginning of this in the section, the number 3 attack vector is know which devices are internet facing with known exploitable vulnerabilities. And so if you don't know what the device is, and you're not going to know whether it's got a known exploitable vulnerability or what the mitigation should be. So again, tools like Medigate it's exactly what we do. And here are some of the findings we had within, but it's not at the top left, it's not only medical devices. 77% of hospital information systems have KEVs, and 63% of them are found within healthcare. So out of all the known KEVs, 63% are found in healthcare, and 23% in medical devices. And 93% could be remediated with an OS patch or upgrade. But guess what? That doesn't happen as easily. It's not the panacea. It's like, oh, get a patch, no problem. For those of you who do patching, you know that it not only is it difficult, labor intensive, you got to try it, you got to find it, you got to try it on one and then roll it out. But it often takes time to even get it from the manufacturer. And then what do you do in the interim? Network segmentation. Do you find you live that in your world, Skip?
Absolutely. I mean, all things equal in healthcare, quite frankly, we're all in the same boat, faced with the same challenges, and it becomes a question of knowing what you have to protect, and what tools do you have available at your disposal to protect them. So it's always a process. I would liken it to my clinical days. It's a process of triage and treatment based on the most critical. And so I always try to keep it simple and focus on the things that we can actually address in a quick fashion.
Yeah, I think and I highlight network segmentation here is often required because until you can get that patch, you got to do something about the device, because you're not going to get rid of it because it's too expensive, and just buying a new one, you're not going to be able to bill for more. So basically have life support on life support. That's what we do at HTM, right? And so the network segmentation, as we move forward in the present, you're going to see that was a enhanced CPG. So it's asking for network segmentation because they know you're going to need to do it. You can see over on the far right, network segmentation was down there, like I was just talking about. But the attack vector number 2 is, vendor supplier cybersecurity requirements. And Skip, you were talking about that, and Change Healthcare is an example of a supply chain type of attack. Huge problem. It's already cost them $112 million, and I'm sure that's only going to rise. But the impact that it had across the industry was tremendous, and I think that the number of attacks we saw last year that were a third-party compromise were huge. And as I look into the data that we had, a lot of devices are remotely accessible, and they use they're designed for connection, Skip. So how do you balance that in your organization?
It's a challenge because the various ways that vendors access systems on behalf of the healthcare organization, they don't have enough people to staff the floor to babysit these systems and take care of them. So they try to create a scalable method to reach into an asset or have it phone home, to use the term. The asset itself knows something's wrong and it makes a connection out to the manufacturer's help desk or whatever. Either way, it presents an entry point into the organization and to the asset. And it boils down to, what is the method? What are the security controls, protocols? You've got remote desktop protocol here as one of them. Is it encrypted? Are they able to access PHI? There's just a whole lot of things that go into the evaluation of a remote connection and the various use cases that are necessary to support and remotely administer or break fix these assets. And it presents a challenge because in a sense it becomes or can become an unlocked door or window.
Awesome. And as we move over just to the enhanced, I'm not going to go through all the enhanced, but the one I wanted to point out, expand out, double click on, is the asset inventory. And whether it's the NIST cybersecurity framework, almost any framework in cybersecurity, they tell you you need to know what your hardware, your software, and how everything's talking to each other. It's the first step. Otherwise, you're flying blind, and that's most hospitals. So, but identifying unmanaged, you can see the line item there, unmanaged devices is difficult. Most organizations, a lot of HTM people don't understand that there are unmanaged. There's managed and unmanaged. What are they? But I'll tell you, unmanaged devices include the network connected medical devices. And if you look at the foundation of where these HPH CPGs came from, they came from the healthcare industry cybersecurity practices documents from HHS. And on practice number 9, where they're talking, these are the things that you're going to need to be able to do to medical devices: asset management, endpoint protection, identity access, network, vulnerability. There's all these to manage the asset inventory of unmanaged devices. It's very, very difficult. And again, this is where Medigate specializes in and provides you with that additional visibility into all the unmanaged devices as well. And so I was wondering, Skip, can you talk about maybe the difference as you see it between managed and unmanaged devices?
Sure. Often the term Active Directory Domain Association is an indicator of its managed, because in order for it to be joined to the domain of a network in an organization, somebody has to be aware of it. They have to perform the act. So often we have medical devices that are placed on networks that aren't domain joined and aren't known to the organization. So they're not a part of the asset inventory. Historically, over time, a hospital ordered something, it got put on the network to go into use in the clinic, in the clinical areas. And as IT and cyber have evolved, Now it is important to know what's on the network, who has an association to it. So if we have a need, we know who to go to get to the relationship with the vendor, look at the contract, the support agreements. More importantly, it's hygiene. Is there a maintenance practice that relates to cyber hygiene on those unmanaged assets? Being able to identify them as, hey, this thing isn't managed. We don't patch it. We didn't have it in our database. We figured out it was there. Now, how do we wrap around it our controls, our operational aspects of ensuring it's patched and up to date? Again, that cyber hygiene aspect. And more importantly, what mechanisms of support? Because often the vendors will provide some form of cyber control and hygiene within those support choices, historically choices in the contract, and often get removed for budget reasons. And so there's a lot that goes into that. Let's just say that unknown to me on the network and not associated with any people or tools constitutes an unmanaged asset.
And that's pretty standard. That's a very standard term, and it is a very standard problem in hospitals without a solution like Medigate. And if correct me if I'm wrong, but that's kind of where you started on this journey. You saw that you got Medigate and you solved that problem, and that allowed you to start this journey.
Absolutely. At the point of entry, I knew what I had. I could estimate what was out there on the network in terms of count. And the question became, of all these that I know, what about all these I don't know? And so it started the process of finding a technology or technologies that could fingerprint the things that are running on the network so that I have a clear understanding of everything that's out there, what its function is, and begin to establish that inventory, and then begin to establish the relationships to the vendors and the people that may serve in a support capacity so that we can bring them into our fold, if you will, and then more importantly, get them to a managed state at some point in that process.
Awesome. And so kind of bringing this home, if first I'll just go back to the asset management piece and inventory that we were just talking about. The ability to identify all those documents, all those unmanaged devices. There's different ways to do it. Different vendors in our space do it different ways. Some use AI, where it's really kind of looking at all the behavior on the network of the devices and kind of guessing in a way what they think it is. Whereas Medigate, one of the main reasons we are best in class 4 years in a row is the way we go about. We use AI where it's appropriate. It's not a problem. But device discovery and identification isn't really the place for AI. The best way to do it is by opening up the communication packets across the network that device is sending, and we've learned how to read them. So we've learned how to speak in Siemens or GE or Medtronic. And so we can read the packet of information, which tells us everything about the device. We're not guessing at all. We know everything that there is to know about the device, the make, the model, the firmware, really everything. And so our accuracy is when we do comparative comparisons, side by sides, always much higher. And so that's probably why we have such a much larger majority of the market is largely due to do you want to see 75% of your devices, or do you want to see 100%, right? If you're going to go through this labor of love. So that's kind of the inventory becomes very, very important, and that sits square. Inventory is going to sit squarely in HTM's court. So make sure you do, if you're looking at solutions like this, don't trust me. I'm a vendor, but don't trust the other guy either. Do side-by-side comparisons. Best way to do that. So cybersecurity, patient safety, we all kind of understand that now. The government's understanding that. They're seeing that more and more. And they've stepped in and said there's regulations. And I just can guarantee you that those leadership, when they find out that 2 to 4%, this is really new stuff, guys. I'm guessing your leadership doesn't know this yet. 2 to 4% of their revenue for Medicaid, Medicare is at risk, and there's going to be audits. It's coming your way, and you're going to be involved if you're not already, and maybe to a greater extent. And so there just needs to be investments. That's what the money's for, to solve the problem. They know that everybody's got the problem. So Skip, would you know, you've got a lot of history here. Those incentives don't start for maybe another year or so, and the penalties a little bit after that. But would you say go? You got time, wait, or would you say you probably need to get started now on figuring out how you're going to address these new upcoming regulations?
The time is yesterday. You got to get on it, because you know, often you don't know what you don't know, and as you begin to peel back the layers, you reveal things that you weren't maybe anticipating, and so you have to course correct often. You know, fail forward quickly, so to speak, so that you can recover as quick. So it's absolutely imperative to get going. And I would also say that, as ominous as it sounds, the opportunity here is huge. And what do I mean by that? We have the opportunity to have a direct impact in a positive manner to the care of our patients and our clinicians that have to perform the work, to ensure they have the tools at their disposal to take care of the patients to the best of their ability without interruption.
Nicely said. So I don't know if we have any time for any questions. I don't know if questions came in or.
Well, we've got time to squeeze one in before ours up. So one question a couple of people have asked: how many hospitals are included in this analysis?
Well, over 2,000 hospitals have been included in the analysis. So we're looking at data across 2,000 hospitals, and over 2 million devices were included. And this is global as well. So it's a substantial study.
Perfect. Well, as we're nearing an hour, if anybody's got any further questions, you can see Ty's email address on the last slide. So please feel free to reach out to him. Thank you, Ty and Skip, for your time today and for a really great presentation as usual. I'd like to encourage everyone to visit today's sponsor to learn more about the services they provide to the industry. So please visit claroty.com. As promised, the answer to today's trivia question is Georgia. So congratulations to our winner, John Graham in Ohio. So enjoy your gift card, John. Just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit from the ACI, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. If you've missed any of our past webinars, including any by Claroty, please visit webinarwednesday.live to view our whole webinar archive. We'll be back next week with another webinar and, of course, another 10th anniversary prize. So please visit webinarwednesday.live for more details and complimentary registration. Thank you once again for your time today, and I hope you all enjoy the rest of your day.